Hello, everyone. Welcome to today's webinar, RNs in Primary Care. Before we begin, let's go over a few housekeeping items. If you're on the line and have not yet connected to the webinar, click the link in your confirmation email. Your browser may prompt you to download and run a file. When you're connected, you should see the presentation on your screen. If you have any questions, you can send them via Zoom's Q&A function. Please take a moment and find the chat bubble icon near the bottom and center of the webinar screen. You can type and send questions throughout the presentation. We'll compile them and take time at the end for answers. When the questions have been answered, we will be giving away a gift card. Stick around because we'll be randomly selecting someone from the list of people still connected to the webinar. Also, mark your calendars. The next big UHIN event is the UHIN Annual Forum next week on May 27th from 11 to 3. We'll be featuring virtual Ask Me Anything sessions with the Deputy National Coordinator of Health Information Technology, Stephen Posnack, the Executive Director of the Office of Policy, Elise Sweeney, and other distinguished guests who are experts in healthcare data and policy. The event will finish with a panel discussion of Utah's healthcare landscape after the pandemic, featuring Utah's Lieutenant Governor, the CEO of the Utah Medical Association, and the CEO of the Utah Hospital Association. You can register and see additional upcoming events at uhin.eventbrite.com. That's uhin.eventbrite.com. This webinar is being recorded, and a copy will be made available to all attendees after the event. Now it's time to begin. Josie Moosman is a clinical manager and registered nurse at the Wayne Community Health Center in Bicknell, Utah. She has worked with patients to manage their chronic illnesses, as well as in quality improvement, infection control, emergency management, risk management, and as a super user for the clinical EMR. Josie currently serves on an advisory board for tobacco cessation program with the Center for Hope and as part of the Quality Improvement Forum at AUCH. Josie, I'm handing the time to you.
Thank you. Welcome, everybody. I appreciate you coming and listening to what we have to say, and hopefully you're able to take something back from it. So we'll just go ahead and get started. Here at the Wayne Clinic in Bicknell, we, well, first of all, let me let you know, I don't have any disclosures. And then also, these are some of the companies that we've worked with: the University of Utah College of Nursing, NEPQR for transforming primary care, Co-Manage Health, and Allidaid, that's helped us develop some of our RN-led programs. So here at the clinic in Bicknell, we have had RNs here at our clinic for a long time, but it generally was just one, and we used them more as a glorified MA than we did as having them work to the top of their licensure. And so when I started here as the clinical manager, we really wanted to bring that around and use RNs to the top of their licensure and be able to really use them to help our providers and decrease some of the burden that they carry. So our objectives today is we just want to discuss how we brought nurses to the work at the top of their licensure, discuss how we decreased provider burden, and review a potential revenue that nurse-led encounters bring to our clinic. So we're going to go through each of the encounter types that we have, and then kind of discuss the workflow that we currently use, and then talk about billing after that. So when we had RNs in our clinic in the very, very beginning, they were just doing our regular nurse visit type stuff: blood draws, blood pressure checks, injections, immunizations, things like that. But then we really found that there was a way to use RNs in primary care to both benefit our patients and our practice. So we've incorporated annual wellness visits, transitional care management visits, chronic care management, high intensity protocol, end-of-life discussions, and then anticoagulation management in that. So these are the nurse-led encounters that we'll kind of review today. So our regular nurse visits are blood draws, injections, immunizations, x-rays, blood pressure checks, dressing changes, suture removals, wound care, phlebotomies. We've recently started doing NSTs and initial intakes for our OBs to kind of get their health history and things like that. These we noticed weren't giving us a ton of revenue. We are on a PPS rate because we're an FQHC center. Some of you guys that are that get paid based on oh my goodness, I just forgot the word. But based on your encounters, may have a different reimbursement than what we have, and you guys may be getting reimbursed for these type of visits better than what we do. So we wanted to kind of expand this and say, how can we really push our RNs to work at the top of their licensure? And one of the biggest things that we wanted to kind of do is not replace our providers or do things without them and not have them involved in the care. It's really an extension to our providers, like an extra arm to help them out with kind of this overwhelming times that we've seen coming forth in the last 5-10 years of really being pushed to do more and chart more and see more and all of that. So our first thing that we incorporated is annual wellness visits. Our nurses do these as a nurse-led AWVs, and over the past couple of months with the COVID pandemic, we have seen this transform a little bit as well, and so we'll kind of discuss that. So what our nurses do, and right now we're doing this in person and on telehealth, is assess for risk factors for the patients. They go through all of the questions. We have templates set up in our EMR, exactly what we need to discuss with the patient. They also assess the patient's health history. We evaluate all the preventative medicine needs. And then we do a warm handoff with the provider. When the patient's here in clinic, that's a face-to-face warm handoff with our recommendations and the risk factors that we've identified. And then on telehealth, this is kind of transformed where our providers were doing that warm handoff more via telehealth and things like that. So it has kind of changed over the last couple of months. But then we also kind of work on that follow through on our preventative medicine needs as well. So our RNs will go in the room, run through everything with the patient, do their clock test, do their health history, identify risk factors, and place that all in the notes. So the notes ultimately almost completed by the time the provider gets to the patient. They just agree with our assessment and say, yes, I agree with the RN's risk factors that have been identified and the plan to go out from there. So some providers I've noticed have had kind of a pushback on, I don't want somebody else doing that. But then we've had some providers that are like, man, these RNs are going to come in, help us get our work done. And we work together as a team to ensure that the patient care is at the highest level that it can be. So AWVs is always transforming, but it's really something that gives gratification to our RNs here at the clinic. So the next nurse-led encounter that we do is transitional care management. Our RNs identify patients that are in need of TCMs. We work with our ACO to identify those patients that are being discharged from the hospital, but then all of the documents that are coming back through our interface are filtered through our RN. She kind of runs through those, gets the everything kind of going and understanding what happened with their visit at the ED or with their inpatient stay, and then they make that initial TCM call and that initial contact within the first 3 days with the patient to get that contact and then arrange for the TCM visit with the provider. And again, we're doing these TCM visits both telehealth and in person right now. They do a warm handoff with the provider saying these are the things that we've identified that we want to follow through with. Our biggest thing with transitional care management is trying to help our patients stay out of the hospital or avoid readmission. So we do a warm handoff, and then the providers often will come back to the RN and ask for follow through with follow-up items that we identified through the TCM visit. This is also a really, really great way to identify candidates that are good good for chronic care management. The RN can identify trends with a patient that they see this would be a good candidate, and they have that discussion with the provider. So that leads into the next RN-led encounter, which is chronic care management. We have 2 chronic care managers here in our clinic, one that does mental health and one that does regular chronic care. So this is kind of the way we envision it, is like a wheel with a spokes, and our RN and the patient are in the center, and then they're communicating with pharmacy and our providers and outside providers and oxygen companies and diagnostic imaging to really make sure that that patient's care is followed through with and is the best that it can be. So they spend at least 20 minutes of non-face-to-face contact with a patient each month. This is sometimes more, sometimes less. The ones that we don't get the 20 minutes on, we don't bill for. But the ones that we get at least 20 minutes on, we bill for. We, like I said before, we get a PPS rate, and so we only are able to bill for that 20-minute time slot, where other people can bill for 20 minutes, 30 minutes, and I'll show that later when we go through the reimbursement. So then they identify need areas, create care plans and goals for the patients, ensure follow through on all the patient needs, communicate with the entire care team. It really does take the entire team to make CCM successful. The entire team has to be on board and working with that patient to meet those goals. Some patients are on CCM for a long period of time, and some of our patients graduate after a couple of months and are able to go off, and then the next time they need to be on, we put them back on. So this does have the patient does have a copay with this each month, so that's something to consider too. So, and then another area that while we are going through CCM, that we developed is these high intensity protocols. Right now, we're just doing these for hypertension and diabetes patients that are uncontrolled. And what this looks like is that our RNs really work really closely with that patient for about a 4 to 6 week period of time to work on getting their diabetes or their hypertension under control. So we manage care in a high intensity protocol identified by our medical director. Our medical director has set out protocols and standards that he wants us to follow. If the patient's blood pressure is out of control, I want him to have lab work done, and we're going to check him out with a blood pressure cuff. We're going to call him twice a week. We're going to keep him with a log. Then we discuss, then RN does weekly calls with the patient. She assesses barriers to care. And then we have a group that comes together once a month to discuss those patients and identify areas that we can do. We have pharmacy there. We have admin there. If we identify that insurance is a barrier to getting their diabetes under control, we have our admin team there that helps get them signed up on insurance or finds out ways that we can help them with their care. Our RNs, the providers, everybody's in the team is there at that meeting to say, hey, does this patient need a CPAP test? Does this patient need an overnight oximetry? Does this patient, could we try this medication with the patient? And they really work together to pull out the best success for that patient. And we have seen a lot of really good successes with hypertension, mostly diabetes. We're still on that curve to developing that. We're going through some DSME stuff, but the hypertension we've seen some patients being able to turn around their hypertension control rates within 4 to 6 weeks, and then they graduate and we put on another one. We identified that RNs can generally handle about 15 patients at a time, 10 to 15 patients at a time on these high intensity protocols. Beyond that, it kind of gets a little overwhelming, and they can struggle with making sure that things are getting done for each patient. So as soon as one graduates, those providers, we have 3 providers in our clinic, and so they're able to say, hey, I want this patient put on. Each provider has 5 patients that they can put on those high intensity protocols. As soon as one graduates, they put on another one. So, and then the RNs also arrange for specialty care and diagnostic testing. But they're really kind of that central hub for the information to say, this is working, this isn't working, what do we need to do to change? We put these patients on our CCM program to get reimbursed for it as long as their insurance allows it. So that we do get some of that, and as long as they meet the criteria for CCM, and we can kind of talk about that some more as well. The next RN-led encounter that we've identified and are practicing is advanced care planning. The RN have really been trained to discuss these end-of-life things with patients. They discuss the end-of-life planning with patients and family. They provide the patient with appropriate paperwork, and as all of us know, advance directives and post forms can be so confusing for patients. So they really go through each section of the advance directive, discuss that, and then arrange for signatures and things like that to happen. But we really want that patient to have a clear idea of what they're signing and what they're putting down on that advance directive or that pulse form. And the RN we have found to be the best person for that. Our providers are super busy and don't have a lot of time to be able to spend doing that explaining and that extra work. So this is billable, and we'll talk about that again here in a minute. Another area that we've identified is anticoagulation therapy at home. So we have a lot of our patients on MDINR, but we're adjusting their medication both in clinic and when they do their MDINRs. But the reimbursement for this is basically only if they're on an MDINR or home testing system. So our RNs ensure the patients are tested regularly. We have a program that we work with MDINR that sends us alerts if it's been too long, that we can set up times when they need to come back to have that done. They evaluate the INR results, and then we adjust the dose based on set protocols that by our medical director. Out of range INRs, the nurse will adjust the dose, and then for the encounter onto the provider to ensure that they agree with our changes. And then this is something that we've done for quite a long time, but just now have started talking about reimbursement for that. So next we're going to talk about reimbursement for all of these encounter types. And I have codes that are set, but everybody's reimbursement is going to be different, as many of you guys know. If there are any billing persons on the call, what we get reimbursed or what you guys get reimbursed may be very different. You might be on a PPS rate or a set rate. So the numbers that I put on the slides are what we're getting. So you may see some difference there. So the first one's AWVs, the reimbursement. So approximately you're going to get the same reimbursement as what you're seeing currently for AWVs, because a provider's signing off on that, and they're able to review that note and send it out. So your reimbursement is going to be about the same. We're getting approximately $220 for AWV, and again, that's on our PPS rate. So the G0402 is the initial, the Welcome to Medicare G code for that, and then the G0438 is the initial AWV if they're older than 65. Then we have the G0439, which is all subsequential AWVs, and then for SQHC we have a code of G0468 that we bill along with that, but we only get reimbursed for one of those. So that's kind of our reimbursement for AWVs. We've seen reimbursement come back. It's been very successful. We haven't had any issues with it so far, as long as we cross our T's and dot our I's and make sure that all the all the points on AWVs are completed. The next one is TCM. So there's 2 billing codes. We only bill the 99495, which is the follow-up within 14 days, but there is also a CPT code for if they've been billed within 7 days, which I do think gets a greater reimbursement. But TCMs, this is all that we bill, and we bill this on the visit, not on the initial phone call. And yeah, so the next one is CCM. We get approximately $42 a month back on CCM. That's our PPS rate. Those that are on the set rate will get more based on more time that they spend with them. But because we're an FQHC, we're unable to bill for the additional 30 minutes or the 60 minutes with high complex. So the 99490 is at least 20 minutes of non-face-to-face time with any clinical people. We have currently use ECW as our EMR, and there is a tracking system on that where anybody on the care team, any face-to-face time, so if the MA is calling and talking to the patient about their medications or their lab results, they start the timer. We start that timer because that's non-face-to-face time, and then they'll stop the timer when they're done. And that also includes some of that charting time. So when they're typing in, oh, the patient said this or this, we're including that in the time for the timer. And then ECW collects all of that data and puts it in and allows us to know how many minutes for the month that we've done with that patient. Sometimes we don't get 20 minutes, and that's okay. We just don't bill it for that month if the patient didn't need it. But that doesn't always mean that we take them off of CCM either. It just may have been a month where they didn't need as much non-face-to-face time as the next month or the month previous. The 99491 is at least 30 minutes of non-face-to-face time. The 99487 is at least 60 minutes of non-face-to-face time with a complex patient. This does have to be reviewed by a provider. And then the 99489 is an add-on billing code for each additional 30 minutes above that. So reimbursement for advanced care planning. Advanced care planning, the first 30 minutes, that's actually all that we bill. We don't do the additional 30 minutes because we generally see that we can put all of that within the first 30 minutes of our advanced care planning. So the 99497, but if you do have a really complex patient, you can bill out the 99498, which is each additional 30 minutes after that. The next one is the reimbursement for anticoagulation management. This is something that we haven't had a ton of success with yet, but I did want to put it in the slides so that you guys were aware that there is reimbursement for this. Reason why we've had issues with reimbursement is because of our FQHC status and our PPS rate. This is something that Medicare hasn't reimbursed us for yet. The G code for that is G0250, so that it is available if that's needed. So next I want to kind of talk about our future plans and kind of the things that we're pushing forward to move on and even enhance this even more. So we would really like to see some nurse-led provider overseen visits, things like UTI, strep, flu. When those patients come in and we can assess that and say they're a great candidate for a strep test and run the strep test as long as that's positive. We'll have set protocols for what will be written, and the providers will send those over without having to see the patient. Same thing with flu and UTIs. This is something that's in the distant future, and we haven't gotten even to the logistics of it yet. But it's something that we really want to help with so that the providers can take that time with the patients that they really need, instead of having to take a 10-15 minute appointment to see a strep test. That's something that we could do for them. So like I said, this is in the future at some point, but this is where we would like to see nurse visit or nurse-led encounters move to, is kind of working side by side with those providers to help them get the most out of their day that they can. So I just wanted to give, that's kind of the end of my slides. We're going to open it up for questions here in just 1 second, but I did want to kind of give a shout out to the University of Utah. They have some great programs for RNs going into primary care and some great financial opportunities to pay for schooling. I'm not getting reimbursed by saying any of this, but if you have people in your clinic that are looking into going into RN in primary care, the University of Utah is a great resource, and they're developing their curriculum to really make it so that those RNs get the training that they need to be able to come in and help with some of this stuff. We're taking on preceptors and things like that to really, really make primary care the future, because I think that that's where we're going, is, you know, out of the hospitals and out of the ERs, and really trying to keep our patients out of that area and save costs for both patients and for the healthcare industry. So they have some great RN to BSN and BSN to DMP programs that if you have people that are in your clinic that are looking to move forward, they should look up. So we'll go ahead and start with questions if we want to. I think they were going to read them.
Perfect. Thank you,
Okay.
Josie.
Mm-hmm.
So we already have a couple of questions, and I'd just like to
Okay.
remind everyone that you can find your Q&A button at the bottom and center of your screen. It might look like a couple of chat bubbles. Just go ahead and keep sending those in. And then also as a reminder that once we're done with questions, we're going to be giving away a gift card, and we're going to pick from the pool of people who are still connected. So make sure to stick around until the end of questions. So the first question that came in is, how do patients feel about the RNs doing more of the face-to-face than the providers?
So this was a concern for both RNs and for our providers, is how is the patients going to feel about this. But we've been very, very direct and upfront with the patients when they come in for a nurse-led IWV. We say, this is with the nurse. Are you okay with that? The provider is going to step in for a few minutes, but they're not going to be reviewing your medications and refilling and doing lab work and things like that at this appointment. All of our patients have been really, really great about it. And we've never, so far, we haven't had any pushback from our patients about any of our nurse-led encounters. We really love that our nurses are able to spend that really quality time with those patients to really dive into their healthcare, to find out those barriers and to find out their risk factors and their needs, and they've done a great job. So both our providers and our patients have really taken this and said this is a great opportunity. So yeah.
Wonderful.
Yeah.
All right, the next question is, what types of methods do you use to track your patients with CCM? Is there something within the EMR to help you?
Yeah, so we talked about this just a little bit, but there are, and I believe that most EMRs have a CCM program. Ours, we had to just have it turned on, and there's literally a start and a stop button to track the time that we spend with our patients. And then there's a whole module within the EMR that helps us identify patients that are candidates, identify the patients that we've signed up. They help us with consent. They help us track the time with the patients. And then they're at the end of the month, it's as easy as like 1 or 2 clicks to send that out to billing. So, I mean, our EMR, as far as CCM goes, is top notch. There's already like care plans that we just run through the questions. It's really, really great.
Well, that sounds like an amazing program. If
Yeah.
I can ask a follow-up, do you
Sure.
feel like the people who don't have that amazing kind of resource for them, is this still something that would be doable, or do you feel like this software is absolutely key to making it work?
I think that you could do it without the software, but I do think it would take a little extra time and a little bit extra effort. And you'd have to develop that within your team to really make it work. But I mean, the software obviously makes it super easy and makes it so that we can just do our job instead of having to work with the logistics. But I think that you could do it without the software.
Wonderful.
Mm-hmm.
The next question says, do you have much experience with Medicaid reimbursing these services? I know they usually follow Medicare standards, but I'm wondering what your experience has been.
So right now, we haven't done a ton of Medicaid reimbursement with this, but it's coming. That might be something in the future that we could put out there and say how this is how we've gotten reimbursed. But we don't have a ton of experience with Medicaid reimbursing these services, but I think they're going to be following, or if they haven't already, Medicare. So.
All right. Next, from Brenda, she says, thanks for the shout out, Josie. The U of U has primary care modules. Any nurse in an FQHC can take this summer free of charge. So I don't know if there's anything you want to add to it, but she wanted to add that little tidbit. Next up, there's a question that says, I like your direction of developing nurse-led urgent care around strep, UTI, and flu. What do you need to do within your organization to do this?
I think our biggest thing is developing those protocols, understanding what our providers, there's a lot to antibiotics and things like that our RNs aren't trained on. So I think what we'd have to do within our organization first is do a lot of training on these are the protocols we've set. This is why we've set them. These are the things that you really need to watch for. As like secondary infections and things like that, because I don't think every strep or UTI or flu is the same, and not every patient. So I think the biggest thing is training, developing the protocols, and then understanding how we're going to get reimbursed for those. If the reimbursement is going to be the same, or if it's going to be lower than if we had a provider in that visit with them. So I think that's what we'll have to do.
Okay. And then another question, it says, how do you put together your patient care plans for CCM? Is this done by the RN or the provider? And how often is it updated?
So our CCM care plans are done within our EMR. There's a series of questions that the EMR has set up that identifies barriers to care, that identifies resources that the patient has or needs. It's a long care plan, and it is done by the RN, but it is viewable to the provider and the care team so that everybody's kind of on board with what the care plan is. It's also provided to the patient, whether they're in person, we can print it and give it to them. It helps us set goals. And then I believe we're updating it once a month, but I'm not positive on that.
Okay. Next question, is CCM required to be done by an RN? I know many clinics are using their MAs to complete the care plan.
I don't think that CCM is required to be done by an RN as far as like the time that we put into it, but I do know that I think that it's better ran by an RN that has that knowledge base to really look at that and create the care plan and do the things that, understand. I mean, those of us that are nurses have gone through, and how many care plans did we set up during that time? I mean, I think I did more than I can even count. MAs just haven't had that training, but I mean, I guess if you could train the RN to do that, or the MA to do that, I think that would be doable. I'm not sure on the logistics if an MA can do it as far as CMS is concerned. That's something we'd have to look at.
Excellent. All right, we've run out of questions for a moment, so I'm going to give it just another couple seconds to see if any more come in. If they don't, then we'll go ahead and give away the gift card.
Okay. While we're doing that, I will kind of let me look at the CMS guideline for chronic care management. I think they do say in there whether it can be done. I know that the time spent non-face-to-face can be done with an MA, but I think that the care plan, I might be quoting myself wrong, but I think it does need to be done by an RN, or at least overseen by an RN. So.
Okay. So while you're looking that up, it doesn't look like we're getting any more questions, and so I'm going to go ahead and give away that gift card. For those of you still in attendance, I am using a random number generator to pull someone from the list of people who are still connected. And it looks like today's winner is Amber Reese. So Amber, we've got your email from your registration, and we'll be reaching out to get that e-gift card to you. So for anyone who wants to stick around long enough to hear the results of Josie's foray into the CMS guidelines, go ahead and stick around. For those of you who feel complete for the day and are ready to move on to the rest of it, feel free to do so, and we thank you very much for your attendance. Remember that next Wednesday, the 27th, UHIN is doing that big annual forum, and we hope to see you there. Thank you very much.
Thank you. Okay, so looking at the CMS guideline, if you guys go to cms.gov /outreach and education, or if you just Google CCM CMS guidelines, there's a downloadable PDF form. I don't know if there's a way that we can send that out, and that gives all the details of what has to be and doesn't have to be done on CMS or CCM. According to CMS. So we can send that out if there's a way to do that. Do you know?
We're going to be sending out a copy of today's recording to everybody, so we can also send any kind of follow-up information with that.
Okay, I'll email this to you, and if we can just attach that, it would be probably a good guideline for them.
Absolutely, can do.
So,
And for anyone waiting for the recording, that might take us up to 24 to 48 hours to get out on the website, just depending on how fast it compiles, but we will be getting that out. So thank you. Josie, you are getting lots of comments saying thank you, and we are very grateful for that as well. So thanks to you, thanks to everyone who attended and stayed to the very end, and have a great rest of your day.
All right, thanks so much.